And then we can use a hormone coil that will stop the periods altogether. Maybe there is a little bit of bleeding, but it's not bleeding. So actually, when it comes down to menstrual health, we're not too bad at it. We have got options, and the things that we can do that will help in polycystic ovary syndrome with menstrual health. When it comes to the skin, we've got some things we can do. There's cosmetic things. A lot of people will use cosmetic treatments. There are some creams that can begin to thin any extra hair. We can use male hormone blocking tablets. Okay? They may have some side effects, but they can be quite reasonable at blocking that male hormone problem. And we can use other tablets which have got slight male hormone blocking effects. So overall, when it comes down to the skin issues, we can help, but every patient that I see says it's not as good as I want it to be. So I think that when it comes down to the hormone issues with the skin, then we can do something, but not quite as much as we like to do. Then when it comes into the metabolic imbalance, so we know that there's a higher level of the hormone storage, there's more what's called insulin resistance, and that means you're more prone to getting sort of metabolic upset and pre-diabetes and diabetes in later life. And we can use sort of medications that help with that. And metformin is something which can make the metabolic effects of polycystic ovary syndrome a little bit better. But maybe I'm only seeing that about 1 in 3 women really benefit from it. And so not all patients can. So I think when it comes into the metabolic effects, yes, we can do a bit. You know, we've got some medications that will do a bit. We know that in polycystic ovary syndrome, there's what's called dyslipidemia. There's more fats in the blood. And that can cause furring up of arteries and cardiovascular disease. And we can do something about that. We can use statins to sort of help lower the cholesterol levels, but not perfectly. So we can do well with the fertility and the menstrual control. We can do less well with the skin and with the more chronic diseases. But then, we've heard a lot about this, the weight. Scotland is only the 3rd fattest country in the world. The top one is the US, and I bet you don't know the 2nd top one, because it's a shock to me. It's Australia. You think of all these beach bodies, but it's Australia. And in Australia, there is sort of, in Australia and the US, we know that up to 80% of women with polycystic ovary syndrome are overweight or obese. Okay, it's not as much as that in Europe, but it can be an issue. And why is that an issue? Why do the women with polycystic ovary syndrome have issues with their weight? Is it because they eat too much? The answer is no. Is it because they exercise too little? The answer is no. And what happens is if you think about it, if you're gaining weight, it has to be something about your intake and your expenditure. So if you take too much in, you'll gain weight. And if you don't spend enough for exercise, you'll gain weight. We know that those with polycystic ovary syndrome generally don't eat any more than anybody else, and so therefore it must be something to do with energy expenditure. And this is the energy you expend. Now, see that running along and taking it from there, that exercise that you do only expends about 20% of your energy. So 20, maybe if you're Andy Murray, it might be a little bit more than that, but 20% of your energy is just by being physically active and doing that. And when it comes into the big bulk, the 65% of all the energy, that's just staying alive. It's your brain thinking, your heart beating, sort of, your liver working, so all these things. And that leaves sort of 15%. And what that is what's called adaptive energy expenditure. That's energy that the body can expend when it wants to. And that's the good way of burning off calories that you don't need it. And so you might notice this if you have a feast, if you have a big meal, say at one of the festivals, and you eat a lot, and you find yourself hot and sweaty afterwards. And that's because you're burning off all the calories you're taking in that you don't need. Okay? And what we know is that those with polycystic ovary syndrome, whether they're overweight or whether they're not, only can burn off 75% of the calories that anyone without polycystic ovary syndrome can burn off. Okay? And sometimes that means that if you've got polycystic ovary syndrome, it means there's a deficit there. The playing field is not level. So that means you have to exercise 20% more to be the same as anybody else, or eat 4% less every single day to be the same as everybody else. And if you manage that, that's okay. But if you don't, the weight will creep on. Okay? And that's the issue. So we're talking about eating less, exercising more, just to be the same as somebody else. And that's the playing field is not level. And I think that you can see how somebody with polycystic ovary syndrome who's trying their hardest to lose weight and it's not happening can get so disheartened. Okay? Because their friends are eating exactly the same thing and doing the same thing, and yet they may not have the same weight issues. So when it comes down to weight, we're actually very poor. And that's the thing that I think that I take most of all. And I've said already, we're good at fertility treatment, but weight will sometimes stop us at being able to offer that to patients. And I think that can be very frustrating, even though that ends in there. So when it comes down to it, when I see patients in the clinic, the things that I can do worst is probably help them with their weight. And that's why sort of, weight management classes through PCOS Relief are so important. So what I'm going to do sort of now is pass over to Cassia, because Cassia is going to talk about some of the research that she's doing locally to take it from there. So do come in and sit down.
Good evening. Can you hear me okay? Yeah, lovely. So yes, thank you so much for coming tonight, and I'm really glad that I can talk about our research on PCOS today. So as you heard, PCOS is very common. It affects up to 10% of women. And one of the main characteristics of PCOS is increased levels of androgens, so-called male hormones in women with PCOS, including during pregnancy. And this is important, I'll come back to that. So yes, women with PCOS have irregular periods and problems with getting pregnant, but they also have an array of metabolic problems, including insulin resistance, type 2 diabetes, abnormal blood lipids, increased fat accumulation in the liver. But as you heard, one of the main problems that particularly bothers women with PCOS is their difficulty in maintaining healthy weight, as up to 80% of women with PCOS are overweight or obese. And we know that losing weight really helps with PCOS, including with reproductive problems. But as you heard, women with PCOS find losing weight incredibly difficult. So we don't really know what causes PCOS. However, there is increasing evidence that elevated maternal androgens during pregnancy might play a role. So we developed a sheep model of PCOS where we exposed pregnant sheep to increased levels of androgens during pregnancy, and then we studied their offspring. Their offspring developed PCOS, and importantly, allow us to study mechanisms associated with PCOS problems, reproductive and metabolic ones. So as you heard, one of our main research focus is obesity and PCOS, and obesity results from increased energy intake or decreased energy expenditure, or a combination of both. And based on the research of others, there is no evidence that women with PCOS have increased energy consumption as compared to controls. And there is no evidence that they have decreased physical activity as compared with controls. So what about this postprandial thermogenesis, this energy which is burned after eating? So Professor Steve Trank demonstrated that indeed women with PCOS burn less energy after eating. Now, we wanted to know if androgens could play a role. So we studied our PCOS sheep. And indeed, we have demonstrated that the sheep that were exposed to increased levels of androgens in fetal life had also decreased energy expenditure after eating, and they became obese in adulthood. But we also demonstrated that this decreased energy expenditure is associated with decreased insulin signaling in the brain. So we thought, well, if you can increase the insulin signaling in the brain, perhaps you can normalize this energy expenditure. And that's what we did. So we've tried insulin nasal spray in sheep, and we were able to show that it indeed it normalizes energy expenditure. But you may think, well, so what? It was done in sheep. Well, the good news is that we received money to do a trial of insulin nasal spray in obese women with and without PCOS. And if successful, we should have our results soon. If successful, we will be able to help millions of women with this cheap and widely available drug. But we are also interested in the role of adipose tissue, so fat tissue in PCOS. Now, why are we interested? Because there is increasing evidence that adipose tissue function might be altered in PCOS. Now, when we think about adipose tissue, fat tissue, we always think about this unloved tissue. But actually, not many people realize that this is an important endocrine organ that regulates many aspects of metabolism and overall health. Now, the problem is that if you don't have enough subcutaneous fat, which is this fat underneath your skin, extra energy will be stored in different organs. So it will be stored in visceral fat, and it will be stored in your muscle, in your pancreas, or your liver. And this will affect your metabolism and overall health. So, we studied our sheep, the PCOS sheep, and what we discovered was that during adolescence, that subcutaneous fat is dysfunctional. They don't make enough subcutaneous fat. And as a result, in adulthood, they have an array of metabolic problems, and they store fat in different organs, for example, liver. So what do we ask? Well, we believe that if we can intervene early enough in those pubertal sheep, we can perhaps increase making of this subcutaneous fat, which will then prevent downstream metabolic problems in adulthood. And that's where we're going with our next project. But I want to pause here for a minute. So I said that women with PCOS have increased levels of androgens, including during pregnancy. So what happens with males from PCOS pregnancies? Is there any evidence, based on human studies, that sons or brothers of women of PCOS are affected? Well, the problem is there are a very limited number of studies on sons or brothers of women with PCOS. However, there is already an emerging evidence that those males have, again, an array of metabolic problems. They have hyperinsulinemia, insulin resistance, they have abnormal blood lipids, and they also have increased risk of obesity. Now, we also know, based on the human studies, that elevated cholesterol is an early metabolic marker of those dysfunctions in pubertal sons of women with PCOS. So again, we wanted to know if androgens could play a role in that. So we studied our sheep. So we studied the males that were exposed to increased levels of androgens in fetal life. And what we found was that indeed they had exactly the same biomarkers elevated. So they had hyperinsulinemia, they had elevated triglycerides and elevated cholesterol. But we also found that they had altered cholesterol metabolism in the liver, and they had increased cholesterol accumulation in the liver, which then led to other metabolic problems. Now, this was done in sheep, so we need more research to understand. So with that, I just want to say that we really try to shed light on the problems associated with PCOS, especially metabolic problems, and we are determined to find treatment to alleviate those problems. Now, research is a collaborative effort, so I wouldn't be here if not for both four amazing scientists listed here and many others that help us during our project. So, thank you so much for your attention. I will be more than happy to take questions. Thank you.
So don't sit down. I'd like to invite our panel to take a seat in front here now and be grilled by you. So any questions you have? The biggest question is how can you make these microphones work?
I think we can.
The answer is yes. So you're very welcome to address your questions to an individual panel member, or you can address it to the whole panel. It's up to you. But just raise your hand if you've got a question to ask, or give me something just to say, and we'll get you the microphone. It's really difficult. Nobody wants to go first today. Brilliant. Thank you. Yeah, just shout.
Just shout. That was incredibly useful and interesting. Thank you all so much. I'm particularly interested in how PCOS is linked with CP and strokes. And so I'm really interested in what you're saying about the dyspnea, the incidence, etc. Do you think there are any kind of direct clinical implications of what we should be doing to try and prevent CPD and strokes in people with PCOS? You know, screening cholesterol levels or insulin levels?
So I think that we're very lucky in Scotland in the fact that we've got a women's health champion called Professor Anna Glazier, and Anna's big mission in life is to think that what happens is that cardiovascular disease in women is underdiagnosed, undertreated, and we see women during their reproductive life before they get cardiovascular disease, and we find things that make them more likely to get it, and we don't follow that up. And I think that it's really important that there's somebody at the highest levels of government that recognises that and tries to put in things. So why, and if somebody perhaps has got preeclampsia during a pregnancy, we know that they may have cardiovascular disease in later life, why don't we make sure that they're followed up with blood pressure checks and cholesterol checks? With Polycystic Ovary Syndrome, why don't we do that in later life with blood pressure checks? And it's easy to measure blood pressure, it's easy to measure cholesterol. And I think that one of our failings is in the post-reproductive life in Polycystic Ovary Syndrome. The periods may disappear, but the metabolic and the cardiovascular things doesn't.
What's the next?
Thank you. Thank you very much. It's really interesting. I just have a general question about sort of when and how do you think is the best way for women to be diagnosed with PCOS? Because Marissa Duncan mentioned how some women or people are not symptomatic until later on in life, but then we've all sort of been talking about sort of the multi-organ systemic effects of PCOS, including impacts on later life, and so then how do we pick out women who should be offering them, so and screening for cholesterol sort of early on in life, and how do we sort of get to the point where we can advocate for, I suppose, finding out this about themselves if they have this underlying condition.
Okay. So I think there's two elements to that. Is that what do you do once you've got that diagnosis with regards to screening? And the second thing is there things that are preventing us from making that diagnosis to start with? Now, one of the things that can be quite difficult is accessing the scans. But what we've learned today is that because you don't need to have a scan to diagnose Polycystic Ovary Syndrome, you can make Polycystic Ovary Syndrome diagnosis purely on history. And I think that's really important, and therefore education of primary health care providers is really fundamentally important. Now, the latest guidance in polycystic ovary syndrome, the international guidance, has just been published, and they highlight screening strategies. And I think that that is best practice guidance, and so hopefully we'll begin to do that. But what it also says is that perhaps you don't need to have a scan. You can actually decide whether you've got a polycystic ovary by measuring a hormone in the blood called AMH. And AMH correlates to the number of little paused eggs in the ovary. Okay? But the trouble is that the guidance that does that doesn't tell you what the threshold would be to classify an ovary as polycystic or not. And the other thing is that that's a test which is only available in tertiary care rather than secondary care or primary care. For interesting reasons, because it's used as a test of the number of eggs in the ovary, and people will go to have that test to be reassured about the number of eggs in the ovary. And sometimes if you're aged 40 with a good number of eggs, you should be falsely reassured with regards to your fertility. But if you're young and you've got less number of eggs, there's very little we can do about it, and it can cause a lot of distress. So I think that it might be that we can use a blood test to help in that diagnosis, but more importantly, the diagnosis is about history. But then again, a lot of it, particularly in ethnic minority patients, is about the stigma of going to the GP and talking about periods and talking about skin and talking about what's happening just now. And I think that we need to demystify that and allow that conversation to happen. And I think that's why the PCOS Relief charity, by allowing people to talk about things, is important. And you might want to talk about the challenges of talking about periods when you're young, particularly when you're young and have maybe a South Asian background.
100%, and I think a lot of people here, especially females, how often do we talk about we're very social in talking about this is what's going on, this is what we're feeling, but how often do we actually say, by the way, I've not got my period this month? And how often the first thing we think when we don't have a period, oh my God, are we pregnant? You know, so how often are those sort of things the first point of things that we think of, as opposed to saying, do I have a women's health condition? And I think what's really important is, once we start to normalise what is a woman and a female is meant to be seen as having a menstrual cycle, we will actually understand that actually females may not have a period, and how do we support them? And coming from an ethnic minority background where fertility is so important, to be told that you've got a condition that is linked with infertility or you may struggle to conceive, for me, that took away me being as a female, unfortunately. And I never knew how to deal with it, and to be honest, I never wanted to believe that I had this condition. But today I sit here with education, and today I say that I'm actually blessed that I've got PCOS, because I'm able to advocate it, and I'm able to show people that despite being from a community, despite being diagnosed with a condition that has links with so much, but if we've got the right education and the right support available, we can live our life healthy and free. So this is why, for me, I take pride in the work that we do, because one, I understand the challenges and the stigma and the taboo, but for us as a charity, we make sure that we have resources available. So currently our charity provides information in 5 different languages, and we look to extend that, because for us, language should not be a barrier to when it comes to health or a women's health condition. So again, there's massive challenges, but I think there's so much stigma, there's so much taboo, there's so much restriction, but I think if we have the right resources available, we will be able to tackle that, and making sure that we're providing females safe spaces and have resources that can support them despite any language barriers or any community restrictions.
One of the things that I talked about was about the chronic conditions such as heart disease and diabetes. And I think that one thing that I perhaps didn't get across is that if you have got polycystic ovary syndrome and you maintain a healthy weight, your risks of all the bad things happening to you are less than if you are obese without polycystic ovary syndrome. But if you've got obesity and polycystic ovary syndrome, it's worse than that. So I think that message, that actually, yes, there's all these things that can happen. We didn't talk about the fact that thick lining of the womb I talked about can turn into individual cancer if you don't have enough periods. And all these things we talk about are some of the bad things, and I think it's important to remember that weight is a huge exaggerator, and if you've got polycystic ovary syndrome and a normal weight, That's so much better than being obese without polycystic ovary syndrome. And I think it's important to contextualise that.
So thanks again for the talks, right? One issue which you didn't talk much about was the mental health issue. And this is a big issue for our daughter who was diagnosed with PCOS. What idea do you have about how mental health is into PCOS? Because you're saying there is no cause so far. I would describe it as more like no known cause for PCOS. So do you have an idea on how it is? And is there a chance to help people with mental health issues?
Okay. Well, I think that the first thing is the recognition that mental health, people with are overrepresenting people with mental health issues. And I think that what the reason for that is unclear. Okay, and I know that Cassia's thinking about whether or not we can sort of look into whether or not there's anything different in the way that dopamine is processed in the brain, or whether it's a reaction to sort of finding yourself not quite as in control of your body as you'd like to be. It's very difficult to know, but I think that it's probably something that is a little bit more endogenous than that, but we don't know, and it's under-recognised. There's things that are certainly under-recognised. Another thing in polycystic ovary syndrome is sleep apnea, where you snore during your sleep, and that can give you huge amounts of tiredness and issues. And that's a big issue with polycystic ovary syndrome. Mental health of eating disorders we've not talked about, but they are massively overrepresented in polycystic ovary syndrome, as well. But when it comes down to the mental health, I think you're right. I think we don't have any tools that are specific to polycystic ovary syndrome. I would like to think that there should be, but we don't know enough about the mental health and the issues and the brain, how the brain functions in polycystic ovary syndrome, to know if there's anything that we should be doing differently to anyone else who's suffering from anxiety or depression, that doesn't have polycystic ovary syndrome. But it is hugely overrepresented, and something that we should screen for when we see those patients.
And can I just add, being from a charity's perspective, we've got a service called Comfort Talk. And as I mentioned, one of the reasons why I established it, because I suffered from severe anxiety and depression. And what made me leave my corporate job, because I just couldn't deal with, in a working environment, and dealing with a condition that made me 22 stones in weight, and I couldn't deal with that, I couldn't accept it, I couldn't, socialise. So for us, mental health is so important, because you are dealing with a condition that has no cause and no cure. But I think what we need to do as a charity, and I think what we need to do as healthcare professionals, is really raise the profile about education, and that comes with GPs as well, because you're diagnosed by your GP to then know that you've got a condition. So for us as an organisation, we want to raise the profile about PCOS, because I think sometimes having more understanding about your condition can support your mental health. And the way how to manage it, you've got the resources, you've got information, you've got signposting available to support that. Because for me, at the time of being diagnosed, I had very little information. But where I am today with so much information, and I'm thankful for all these healthcare professionals that supports our charity, because now I can stand here and say, well, do you know what? 4 years ago, I was depressed, and today I'm proud of being PCOS and advocating for PCOS worldwide. So having the resources and the support for people to support in education will support your daughter. And again, if she wants support through our charity, then please do ask her to get in contact.
If I ask a question, when you get a microphone and you're never sure how loud you're going to be when you speak into it. I had a brilliant question for you, Chad. You just answered it in your previous one. So I was standing here thinking, what's an even better question that I could ask you? And I'm actually going to flip to Cassia, if that's okay, because this is a question I've always wanted to ask her. Why sheep?
Sheep are very model than rodents, and we are in Scotland. So,
can you expand on that a wee bit?
Yes, indeed. Actually, when you think about we expose pregnant sheep to increased levels of androgens. That's how our model works. And basically, sheep development actually is very parallel to human one. that's why we use sheep. So bees are an excellent model. Also, we can actually, the environment, they are, we are not in stressed environment like rodents, for example, when you work with rat or mice. So these are the main reasons. Anything else, Colin, you want to add?
Well, I think that the main thing is that our sheep, you might think of sheep as being little, but our sheep are 96 kilograms. And that means that they're human size. Okay? And the other thing about it is that if you're thinking about metabolism, rodents, which is what most animal research is done on, are tiny little things that have to burn off so many calories. They have to eat all the time to burn off the calories because they're so small they lose heat all the time. So they've got something called brown fat, which just burns off calories all the time. And actually, humans, tend not to have that. Sheep tend not to have that because big animals don't need to do that. So a lot of it is about the development, because we're thinking about doing things during pregnancy, but it's about the size as well, and the clinical realism. I think is really important. And obviously when it comes down to working with sheep, we're doing a study in women. You've heard about the study that Cassie is involved in doing it in women. Getting all the ethical approval to do that in women was quite difficult, but not nearly as difficult as working with sheep, because they can't be asked whether they want to participate or not. And so the regulation is so reassuringly good. The Home Office are very, very engaged in making sure that the welfare of the animals is paramount.
Thank you very much, and thank you very much for the talks. I think they were all great, and thank you for coming along today. Professor Ringler, a particular question to ask you around about the idea that you're talking about really great with fertility, and I've experienced that in terms of I have a little girl, but I'm still experiencing secondary infertility, and it's because of the weight sort of size, and because of NHS kind of guidelines about being specific kind of BMI. Is there any recognition of, so there's recognition that it's really hard to lose weight, it's really hard to, so even if you're at a consistent weight, that doesn't seem to matter, because your BMI is automatically not the right, it's 3, 4, 5% out, and that has it, and then it's like, no, door shut. So as a clinic, we can help, and we're wonderful, and we can do it, but only if, and so it's really hard. Is there any kind of movement on that, or?
Well, interesting you should do that, because I chaired the Scottish Government, writing group on the basis of that. Now, you might be aware that when it comes down to IVF, that what IVF does is that they've got a BMI cutoff of 30 for funding, and that is 7 tablets a stone, and then taking it from there. Now, there are some clinics in Scotland that do that for any form of fertility treatment, and their argument is, why should you have fertility treatment that you can have something but you can't have something else because of your weight? And I'm very much of the case of, when it comes down to ovulation induction, is non-IVF. People with PCOS don't need IVF, and therefore we should be different. So I fought very hard, because I genuinely believe that the evidence base, if you're going to treat somebody up to the age of 42 and think of all the bad things that can happen in pregnancy, treating somebody with a BMI of 31 who's young and fit and not going to have all these bad things in pregnancy, you're having to think about evidence. But the guidance for ovulation induction, I managed to make it sort of, up to 35, okay? But that was pushed back hard against by some clinics, because I want to be an advocate of doing that. And I think that the saddest thing that I see in my life, and I see it again and again, is patients that I see, I touch base with all the time, that they cannot get their weight down to a level, and then they become menopausal and they've never had a child, and their life would have been so much better and more richer if they'd had that. And I find that really, really sad. And it is a lottery, because if you've got money, you can go privately and you'll be treated, and that is unfair. And so I can don't speak for the Scottish Government, and I speak for, and I follow the guidance that we've been given, but I'm a huge advocate for Polycystic Ovary Syndrome, and I think that when we're talking about it, if you're wanting to have an evidence base, You want to make sure that I do genuinely believe that if you look for the whole, physical, mental, and social health, that maybe having a child, if you're wanting a child, maybe supports that, and not as saying we could do it but we can't because of your weight. It can be very challenging. So I'm a huge advocate for doing that. But and I've definitely tried.
Well, I actually want to say thank you, because 2 years ago, the first one, and I was 30, and it was on automatic no way, and I realised recently that it's 35, so the sort of hope is alive again. So thank you for that. It does make a difference. So thank you.
Thank you for your presentations. I've got 3 really quick questions. The first one is, what's the average age of diagnosis? Is it teens, 20s, 30s, or is it all mainly based around fertility, or is it just when symptoms start? And the second one is, you talked about this metabolic problem. When you compare, say, the US, Australia, and Scotland, we have obesity problems in these countries. What's the difference for PCOS levels in countries where we don't have obesity problems, in Japan and China? Or what's the difference there? Is there one? And my final question was, there's so many apps now, fertility apps, contraceptive apps, Flow, Natural Cycle, Period Tracker, etc. First of all, are any of the charities linked up with these and have any kind of voice on them? And second of all, have they led to quicker diagnosis of people with PCOS?
Fantastic lots of questions. I'm not even sure I can remember them. I'll
think
try
that's
to
cheating.
start off. First thing is average age of diagnosis. I think that one of the very clear things is trying to make a diagnosis in a teenager. And I think that can be very, very difficult because if you're young, your ovaries look polycystic because you haven't fully matured your reproductive system. And so it can be very, and so therefore, if somebody comes to see me and I do a blood sample at the age of 16 to see, do you have polycystic ovary syndrome, there is no normal ranges. So you cannot say if something is high or low or anything because the whole system is developing. So I think we have to be very careful making the diagnosis around that 15, 16, 17 mark. Although you may well be able to do that. But you don't want to be labelled at that stage when everything is still maturing. Most of the diagnosis is around the early 20s, to be honest. But women with polycystic ovary syndrome, I tell them they're like a fine wine, okay? Because they get better with age. So actually, paradoxically, fertility gets better in your late 30s and early 40s than it would be. And the other thing is that in polycystic ovary syndrome, your outcomes at IVF in your 40s are better than the outcome of anybody else in their 40s if they need IVF, and that's because of more eggs to choose from. So when it comes down to fertility problems are less of an issue in the late 30s and early 40s because the changing in hormones as you age makes the hormone imbalance less appropriate. Now, when it comes down to obesity, the way that I think about it is that it's probably about 1 in 10 throughout the world, okay? But not everybody manifests it. Now, if you scan everybody in Princes Street, they'll have 1 in 5 women of reproductive age will have polycystic ovary syndrome, polycystic ovaries on a scan, but only half of them have polycystic ovary syndrome. And the way that I think about it is the more you gain weight, the more those people who've got the polycystic ovaries syndrome end up becoming into that syndrome. Okay, so the increasing obesity epidemic makes you more likely to diagnose polycystic ovary syndrome. But I don't think that there are people who can be as obese as you like who will never have polycystic ovary syndrome because they're not on that spectrum. Okay, and so when you look at some of the research, a lot of the research on polycystic ovary syndrome is coming out of China because there's huge hospitals that just will deal with hundreds and hundreds of women with polycystic ovary syndrome. So even in countries where historically there's not been significant weight issues, we'll still see polycystic ovary syndrome. But as you gain weight, more people express the phenotype of polycystic ovary syndrome.
So
There's the apps, about the apps, sorry, I was wondering if you've got any influence.
So in terms of apps, as a charity, we've not really looked into that, if I'm going to be honest, because right now, as an organisation, we want to raise the profile about the condition itself. And for us as an organisation, where we know that there's so much information available, it's hard for us to say, okay, there's a fertility app that we think this is best. So I think maybe that would be something that we would want to develop as a charity, as opposed to going to a third party, at least because then we know that we're backed up with the information that we agree with, as opposed to agreeing to another organisation. So right now we don't have anything like that, but that would be definitely something that we would look into.
So I don't know about charity interaction with apps, but academics interact with that. So if you go to fertility conferences, which I do, you'll often see posters from some app developers that are using huge real-world data to talk about, menstrual cycle and all of the information. So I think that there is a more academic element to that, even though it's being provided for a different point of view.
And just touching on that, I think I'm going to be a bit controversial. Do you think we should do more as healthcare professionals for people who are, one, not obese, but two, who's also not looking to have children? Because a lot in the recent last couple of weeks as a charity, we've been exposed to members where they're saying that we've got very little support because we don't want to actually have children. So what would your take be on that?
Okay, well, I think
Apologies
that...
if it would be controversial.
No, it's not controversial at all. I think that one of the biggest things is that if you want fertility, we have got excellent fertility services in Scotland that go from secondary care to tertiary care, and it's very well networked throughout Scotland. And I think that fertility care, even though it's a little bit IVF dominant, it's still really good. If you've got polycystic ovary syndrome and you don't want fertility, that you can end up seeing your doctor, and nobody, your GP, nobody else. You can be sent to someone like myself who runs a specific reproductive endocrine clinic. You can see a general gynecologist, or you could see an endocrinologist who might be focusing on one element to it, but forget about the period element to it. So I think that there is a little bit of a lottery about where you might go and who you might see, depending on where you are, because we're probably in a big centre like Edinburgh. Yes, we've got dedicated clinics that we can see people in, but that's not going to be the case in other health boards, and it's not going to be and often you'll see a general endocrinologist or a general gynecologist, and they may well be very good, but they may well be seeing it in the clinic with lots of other patients. And I think the good thing is that my appointments with patients when I first are 40 minutes. And I think that is not the case in general gynecology clinic, because I think that you need that length of time to go through things.
Mick, there's an individual over here, so I'll be waiting very patiently for...
You were doing that secondly.
No, she's got a microphone.
Oh,
She's just gesturing to you like...
I thought you were just...
I'm just going to bring in as a wee discussion point. Do you think we're doing enough for our maternity patients with PCOS? Because I feel the focus on PCOS is very much often in gynae clinics and fertility clinics and in obstetrics, where we feel a bit guilty of minimising it and forgetting about it because we just got pregnant, so that problem is solved. But I guess that's for two reasons really. One, we've got a very motivated and engaged population who we can target in terms of their longer term health. Obviously, as well as Cassie is saying, it's such a critical time for fetal development. And for example, our national guidance doesn't tell us to treat gestational diabetes and PCOS. It's very much down to individual clinician or kind of discretion, when we know that would be done in other places. So how can we kind of utilise that time to question PCOS?
Well, in some research, up to 40% of women with PCOS will develop gestational diabetes during pregnancy, and therefore I think that's something that should be highlighted. But I don't even know whether or not that data is collected when people are doing, when midwives are doing that initial screening. It may well be, but it might not be highlighted. And I think that you should be screening for something which might be as high a prevalence of 40%. Now, when it comes down to one thing which a lot of women with polycystic ovary syndrome say to me is I've been on metformin, and metformin is something that works really well for me. What do I do with that metformin during pregnancy? And I would normally say you would stop the metformin during pregnancy once the pregnancy, and then basically if you're diabetic, you would go back on the metformin. And they did a big study, it's called the PregMet study, where they looked at giving people metformin all the way during pregnancy who didn't have gestational diabetes. And you could say, well, that might stop you getting gestational diabetes, and it didn't really do that. And the only finding that I thought was really fascinating was that if you randomized the patients to get metformin during pregnancy or not, and then you looked at their children at the age of 5, the ones that got metformin had more obese kids than the ones that didn't. And we've heard from Cassia that during development, a lot of things can happen. So Cassia does something for a few weeks to a pregnant sheep, and 4 years later, the offspring, who you have not done anything to, is obese. So you have programmed that sheep to be obese by doing something to its mother for a short time during pregnancy. And therefore, the fact that you can then sort of use a drug in pregnancy, that you can see something changing in an offspring, I think we need to be very careful about using drugs when we don't necessarily need to do it because of diabetes.
Can I just follow that up then with a question for Cassia? If, as I understand it, we're saying that drugs or medications during pregnancy isn't a brilliant idea, perhaps. When, from your research, when do you think is that an opportunity?
It seems that, based on the research we've done, it seems that puberty is the time to really screen and intervene, if possible. So, but again, we need more biomarkers. We need a good biomarker so we can test quickly both at risk. Because obviously, as we said, yes, it runs in families and it increased risk for both daughters and sons to have metabolic and problems with fertility as well. But not every daughter and not every son will have a problem. So we need a good biomarker to screen those at risk, and perhaps then we can intervene. Now, how ethical would be, Colin can perhaps comment, because from his perspective how it looks like. But it seems from the research we've done, it seems that the puberty is the spot, is the time when you want to intervene to prevent the development of future metabolic problems in adulthood.
Good evening. Thank you very much for the talks. I have two questions which are kind of related one to another. So, Cassia, you did mention that there are indicators that PCOS is linked to mothers being exposed to androgens during pregnancy. So, my first question is, are there any known exposure factors which result in the exposure to androgens? And my second question is, because there is a research going on in relation to the male relatives to women with PCOS, is there any research going on that indicates if male bloodline in some fathers can pass on to the PCOS gene as well? Thank you.
Well, to answer your first question, so the problem is that women with PCOS will have increased androgens, including during their pregnancy, which means that there's nothing we can do about this. So when they are pregnant, fetuses will be exposed to increased levels of androgens, and that's what we do with our model as well. So we just kind of mimic this environment of increased androgens during pregnancy. And now, with regards to your second question, yes, there is interestingly some indications, some research papers indicating that also fathers might have increased risk of metabolic problems, but at least based on this very limited research, we're talking about maybe 10 to 12 papers published on sons and brothers of women with PCOS. These are mainly affected. So that the males that were potentially exposed to these increased levels of androgens during fetal life. But we need more research to understand what's going on, why this happens, and perhaps once we have more understanding, we should also discuss if the actual name, polycystic ovary syndrome, is the right name, because it might be misleading.
Well, Cassia, when she was giving her talk, put up a paper. There was a title of a paper. And what that paper was a paper where it was in mice. And what they'd done was they'd given mice a little bit extra male-type hormone during pregnancy. And then, if you do that, then the fetus is exposed to it. But the fetal eggs are there during the fetal development, so they're exposed to it as well. So therefore, your grandchild might be exposed to that as well. But the great-grandchild wouldn't have been exposed at all. And what they showed was features in PCOS in the great-grandchild after treating the mother. So that suggested that they were doing non-genetic inheritance. Okay, and that was shown there. And the reason I'm saying that was because they published that and it was all very good, but then they also published that the same thing could be passed on through males. And that got much more media attention because the males were passing on that as well.
So can I just ask a question of Chand? Chand, you're a brilliant role model for someone who's faced adversity and turned it around. Can you speak a wee bit about your emotion that drove you to do that? Was it anger or frustration, or be inspired by something to turn around and form a charity to support all these individuals?
To be honest, when I talk about what I felt was far more than depression. I actually went into suicide, to be honest. And I don't want that to say that to alarm people or whatever. This is my personal journey. Because just the way that I was diagnosed with the condition, just the way that, one, I couldn't spell it, and two, I couldn't even pronounce it. And once I had to ask the doctor to write it on a piece of paper so I could do my own research. And I worked in a corporate setting. I'm a qualified paralegal. And to keep up with the engagements with work, client entertainment, the lovely buffets, the lovely brownies, the drinks, everything, I was just going on, and I was weight gaining like nothing. Every year I was putting on weight, and weight. And sometimes it's sad because the biggest people in weight are the happiest people, but in reality, how happy are we? Is that just a mask? And I think the way that I developed, or the way that I took it away from me being diagnosed with PCOS, was I was at rock bottom, and I knew this was not right, and I knew that I wanted to make the change. So for me to come from an ethnic minority background, I couldn't accept it myself, to be honest. I was like, I'm going to start up a charity, and everything's in the process, we're doing all the registration, but I can't actually say that I've got PCOS. And I was scared, and I said, when I do all these workshops and all these talks, if somebody asks me, why did you start it? Am I going to say that I've got it? But then I thought, what's people going to think about me? But then I said to myself, you need to change that. That's what's the mistake. We don't want to accept we've got a condition that's linked to this. And that's why there's so much stigma, that's why there's so much misinformation, because we're not educating people. We're not actually saying that we've got this condition, but look at us today. So this is the reason why I started it, because one, I said, there needs to be a change, because there might be another female going through the exact same as me. There's somebody that's just been diagnosed with this condition, that's been given basic information, left to do their own research, probably doesn't speak English, is not in the right frame mind, and they're going to go on the same path as me. Do you think gaining weight is just going to be normal? Having irregular periods is normal. Having excess of hair growth is normal. You've got weight, that's why you've got the hormonal acne, but no. So this is why I said, you know what, I need to make up a charity organisation that's free for all, because nobody should, in my personal opinion, nobody should have access to healthcare with a cost. So for us, it's really important to provide free services, but also services in their first language. So for us, it was more so identifying that, yeah, weight is a problem, diet and nutrition is a problem, mental health is a problem. And again, as I mentioned in my speech, how often does females speak about, we never got our periods, by the way. So having a supportive network for females that can educate, build friendships, speak to somebody that's not even probably in Edinburgh, that's sitting in Glasgow somewhere. Having that supportive network for members can really make the impact. Because for me, it was my journey, that's why I started PCOS, but it's my members led. And this is what's going to raise the awareness, because it's the members that is iterating the need of the changes. I mean, we were honoured to host an event in the Scottish Parliament, and I think that was the real stepping stone. But the feedback that we got from the Scottish Parliament, our members, was the Parliament actually cares about us. There's people that actually wants to listen to us. It's not just policy makers. And I take pride because the healthcare is built with so many females, 80% dominated of females workers, but actually the policy makers are men. You know, and sometimes they need to have the support of females to iterate, to say this is our issues, this is our problem, and this is what we want to do in the charity. So it's my journey, I went to severe levels of depression, anxiety, suicide, but I'm here to make that change, and this is the reason why.
I'm just going to interrupt now a little bit with some technical questions, but you happen to mention the Scottish Parliament, and I happen to notice somebody sitting in the front row here. Ros McCall, MSP. So, Ros, this would be a really opportune moment to hear from you. And I'll get your microphone, because I've lost the other one.
Is it okay if I stand up?
Yes.
Anyone that knows
Yes.
me will be saying, for God's sake, don't do that on the microphone.
I've put you on the spot now, so it's okay to
Yes,
stand.
you said you were going to do that. So, how do we want this to go? Hello, my name is Ros McCall, and I'm an MSP, but I also was diagnosed with Polycystic Ovary Syndrome when I was 29 years old. So I am a PCOS survivor. I think it's important to put it across that way. I only found out that I had polycystic when I was trying to have a child. I got married when I was 25 years old. My wonderful husband Graham and I have been trying pretty much since, you don't need to know all of this, I'll tell you anyway, pretty much since we got married, because he was 30, I was 25, and I thought, you know what, we're reasonably secure, let's give it a go. To be 4 years further on and going through lots of different processes and being disappointed every month, because even though my period had been irregular since I was 14 years old, I kept thinking, maybe this month. And then I would go home and I would go past Boots and I would buy myself a test to see if I was pregnant, and I wasn't. But I still didn't have a period, and I didn't have a period sometimes for months. And then my longest bleed was 9 weeks. It is awful. Now I am so thrilled with the information I've heard this evening, because that was, what, 27 years ago? Yeah, there you go. Anybody good at maths will work out how old I am. But that was about 27 years ago. And I would go to a doctor, and the first thing I was told was, you could do this and wait. I was at Weight Watchers for 3 years. And my best friend, who actually happened to have the same amount of weight as me, joined at the same time. Because let's be honest, let's do it together. You know, we go to the toilet together. We might as well go and join Weight Watchers together. So we did that. Within a year and a half, she had lost all her weight. It took me 3 years to when I gave up, and I was still 2 stone away from my BMI goal weight. So losing weight was almost an impossible thing for me to do. I was running, and believe me, anyone that knows me will know running is not my forte, but I was doing that in the morning, and when I got home from work, I was going out for a walk. And I was monitoring every single one of my calories every single day. I was counting points and counting calories at the same time. And I found it incredibly difficult to shift even half a pound a week. So when you go to the doctor and the doctor's telling you, there's nothing we can do, just lose some more weight. There's nothing we can do, just lose some more weight. So eventually, as I say, I got to the point where I thought, no, we're going to try fertility treatment. And in doing so, that's when I found out that I had polycystic ovary syndrome, and it got to that stage because I was a little bit older that actually I had an endometrial issue as well. What I really want to get across, because the point that I was brought along here was to be positive and uplifting, and I'm not 100% sure I'm doing that right now, but what I wanted to say was I was in a very lucky position because we had started our own business. And that meant that because it was mine, if I needed a little bit of extra time, or if I needed a little bit of extra support, or I needed to just work from home for the day, I could do it. We don't have that facility. We can't do that in business. And there is so much more. I'm taking my personal bit, but I'm going off and I'll put the MSP hat back on. There is so much more we have to be doing in government. Now I'm in the opposition, which means there's not an awful lot of sway I can have as far as policy is concerned. But anyone that knows me, that if I say I'm going to raise an issue in the chamber, I'll raise an issue in the chamber. If I'm going to do something, if we're going to have a debate, and I tell you that now, we'll have a debate. It might take me a wee while to get that organised, because business in the chamber does have a tendency to book up quite quickly. But I think there is so much more we should be doing, not only for polycystic, not only for women's health in general, but we need to be raising these issues. We need to be raising them loud and proud and clear. And listening to everything that's been this evening, I am engaged. You will have a debate on this subject. So, thank you very much indeed. I'm glad to be here. I don't know what else you want me to say, but here we go. Is there any questions for me, or do you want to go back to the really informed panel?
I was just like this. Do we go to sleep? Is that not debate?
The truth of the matter is, I'm a politician. It doesn't take much for me to come up with it. Certainly, as I say, don't give me a microphone. But no, it's we've literally been sitting, listening, myself and one of the works on my team. We've been listening to everything that's been said. I am phenomenally blown away with the work that you're doing. The difference in 25, 27 years on this is night and day. It was a closed door when I was diagnosed, completely closed. And the difference between 28, 29, and finding out in what should be puberty and an adolescence, that time frame made it almost impossible. Now, I'm very lucky. I have a fantastic husband. We adopted two girls because it was just not possible for me to conceive naturally, and those girls are my girls, and I love them dearly. But we found alternative ways to get around the system. What my job now is to change the system. And I really appreciate you inviting me along. Thank you so much indeed. And I'll give you this back.
And I met Roz, and I was the one who thought that Roz should be here, because Roz is somebody, for me, she's inspirational. She's got a condition, but she's been able to achieve great heights, and this is one of the reasons why I was really keen to invite Roz. Because sometimes we feel that we've got a condition that's linked with so much, and for a female, how do we, like, I left the corporate sector, and for Roz, she's one of my role models, because she's been able to have a condition that's had so many barriers, but she's been able to successfully progress and become a woman of leadership. And this is something that we should all be proud of. Never set yourselves because you've got a health condition. Be proud of it and be able to stand and make that change. But one thing, when I met with Roz, I just want to say that Roz said that if anybody had questions that they wanted to put forward to MSPs, then Roz will be able to support us in doing that. So again, if anybody had anything that they wish to raise within the Scottish Parliament, please feel free to contact myself. I'm sure Roz and Moira will be more than happy to have that discussion with you as well.
I am a PCOS sufferer as well, and thank you all for all the information today. I thought I knew a lot about PCOS, but I've learned lots of things. I'm also a former patient of Professor Duncan, and I have a little letrozole baby waiting for me at home tonight. And I guess my questions are around, you talked about the app and kind of the weight and difficulty to lose weight, and it sounds like sometimes it's an uphill battle, and at the same time I feel we're in a society that tells us, oh, you can be in control of your own health, and there is something you can do about it. So, and we see kind of also alternative health solutions to that. And yes, when I was diagnosed, I was Googling, health, like natural ways for PCOS, and you get all these food supplements and all these books. So I guess, what can we do? What is in our control? So we talked about weight gain, but is there anything else that we can control as women with PCOS to kind of make things a little bit better for us?
a very sort of difficult question because obviously the biggest thing you want to do is be, have a normal cycle, have normal weight, and these things are sometimes outside our control. When it comes down to normal cycles, then sometimes we have to use hormones. But the most important thing is to get something that's right for you, because not everyone, is not everything suits everybody. When it comes down to weight, then yes, keeping a normal weight is so fundamentally important. It's so difficult. It's not impossible, but it is very, very difficult. And when I speak to patients about weight, what I say to them is, I say that in polycystic ovary syndrome, you go into starvation mode really quickly. So if you skip a meal, the next time your body will slow down, you'll try to store even more so you have to have small meals regularly and avoid the sugary things. And I also say that normally people will have a small breakfast, a medium-sized lunch and a bigger dinner at night. But in polycystic ovary syndrome, it does work better the other way. More bigger breakfast and a small meal at night and avoid, because what you really want to do is front load your calories so you'll be physically active afterwards. And the worst thing to do is run around all day and sit down, eat a lot, and not then be active afterwards, because of the storage, it'll just all store. And the other thing I say is that some doctors say to patients who want to lose weight, don't exercise. And I'm not that doctor, but they're not daft. And the reason they're not daft is that the studies have shown that if somebody goes for a jog, or goes for a long walk, or goes for a swim or something, they feel good, and they feel good about themselves, and sometimes they give themselves a treat. And that dietary reward is more than they lost by doing the exercise in the first place. So it's exercise without the physical reward. So these are things that people can do, but you're working against a playing field which is not level.
Can I just add in terms of what else to do as well? What I want to say is please don't look at Google, because I know a lot of people say that we've looked up at Google, so don't look at Google. We've got resources like our charity, there's also a charity called Verity, you've got the NHS Informed website as well, so please make sure that you are looking up reliable and accurate sources. In terms of, for example, I mentioned we've got weight management and diet nutrition classes. So in those two services that we provide, they are a 12-week programme, and in that 12 weeks we aim to do different sort of activities with that individual. And with the hope that after 12 weeks they will have more understanding of how to implement healthy lifestyle options after those 12 weeks. Again, if you need further support, then we'll be looking to re-involve you in those 12 weeks, or how do we provide you the after support. But we know that you can't tell a female with PCOS, walk 10,000 steps tomorrow, because that's not going to happen with somebody who's overweight. It's having that understanding about their condition and how we can slowly move you into being active. And this is something that we do because we're supported by healthcare professionals that understand this in terms of making sure that individual is happy, comfortable, but also how to educate themselves in exercise and eating healthy. Because we don't want to say to a female, don't eat carbohydrates. I mean, I know when I was 22 stones, I stopped eating for two years, and I was more times on the floor than I was standing up, but I felt that was the one way to lose weight, but it wasn't. So again, we have that understanding of what people think that should be appropriate, what people are doing, everything like that. But again, having resources available can support you and be tailored for your condition, not as opposed to just doing it for everybody.
And we know that a big trendy thing now is weight loss injections. The Wegovy, the semaglutide, and these weight loss injections. One of the big effects is to curtail appetite, and obviously in polycystic ovary syndrome, the appetite is not hugely raised, but they do seem to work a bit in polycystic ovary syndrome. And what I'd like to see is that in order for the weight management service, the NHS, to use them, you have to have a problem with obesity and an issue with another health issue. And polycystic ovary syndrome doesn't count as that other health issue, and I think it should.
There's one person up there, sorry.
We're running out of time. I've got a question here first.
Yeah, hello. So just I I'm from the PCOS, and so my question would be probably around primary care and accessing primary care. And I think probably Chad, you're very well placed to answer that. But my own experience of accessing primary care and how these different aspects of care is sort of not linked very well together, or just not being able to access that. I don't know if there's any sort of work on that with GPs, and you've mentioned that some new sets of guidelines have been issued to primary care providers. You know, when will, I think my question is, when will women see an improvement in maybe the quality of care or management of this available to them?
Well, the good thing about primary care is that the Scottish Government or the NES, which is the education part for doctors, the GPs pay a bit of money, and then they can attend all these seminars and they use it for their professional development. And I did one on Polycystic Ovary Syndrome for GPs. It was well attended, and it's really recorded, so people will be able to watch it who weren't able to attend. So there is an educational element for primary care as well, and I think that's important, as you say, because that's the first port of call for anyone with polycystic.
Sorry, just the issue is that me, or people I know, or women I know that have PCOS, it doesn't feel it trickles through, because the same answers, box standard answers come back from the GP. Yeah, no way, take this pill and go and lose weight, and that's pretty much it. Oh, and if you have a baby, then we've got
100% agree, and that's where the downfall is, especially when people are feeling that you're not being taken care of because you are just put on a pill, you are just diagnosed. So we totally understand that. However, one thing that I'll let you in a little secret with, as a charity, we are starting to do training for student doctors, undergraduate doctors, GPs and stuff like that, because really, when you get diagnosed, you're getting diagnosed from your GP. So if they're not available, if they don't have the full understanding, don't get me wrong, they're fantastic. However, a lot of females has expressed when at the time of being diagnosed, it's not the diagnosis that they want, or it's not the terminologies. I mean, unfortunately, we had a very young member who was diagnosed, and at the time of being diagnosed, she was told she was going to be infertile. To what point she said, "Yes, I'm not going to try." And for us as a charity, but as an individual, you should never tell a female that you can't conceive until she's at that stage of conceiving. So yeah, I 100% agree with you, being lived experience PCOS, having members that have expressed this. But as us as a charity, we want to raise the profile, and we are getting into the work of where we have collaborated with GP surgeries, and they're referring their patients to us. We will now provide the training to them with the support of our board members that are looking to get on board.
We don't quite have enough tools in our box for treatment, and one of the things is that young women who are potentially fertile are a really, really bad group of patients for drug companies to be interested in, because they're terrified that anything they create is going to end up causing issues if they get pregnant, and then they'll be sued for an abnormality. And so therefore young, potentially fertile women are not a priority for any form of thing. So when I'm using male hormone blockers, for instance, there's a big thing, so you don't even think about giving this to women. And we have to sign disclaimers and everything else as well. So the tools in our box aren't enough.
And just one thing, as a charity, we're involved with NHS Ayrshire. So they're doing a PCOS pathways and guidance that will be made available. So hopefully once that's done, that can kind of support in terms of being diagnosed, what the condition is on primary level as well as patient level.
That's actually exactly the thing that, an actual pathway, how do you access mental health support, for example, how do you access dietary support, how do you access,
So this is in the process, and hopefully the more work we carry out, hopefully this will be made live. But also one thing as well, Professor Anne Glacier, who's the Women's Health Champion, has recognised PCOS, and she has included this in our Women's Health Plan, so hopefully that can support in raising the awareness and the need for more support. But I 100% agree with yourself.
So folks, I know that the time is ticking.
Should we just have one more? I think that, did you want to ask a question?
It was more out of curiosity, because you mentioned that PCOS can be detrimental to the endometrium, and I was wondering if that increases like the chances of someone getting endometriosis, and if they're more likely to develop it, and then if they do so have it, could treatment for either of those disorders like correlate or like interact or be, you know, like interacting negatively with each other?
So endometriosis is again common, about 1 in 10 women. It tends not to be the same. If anything, women with polycystic ovary syndrome seem to be slightly less likely to get endometriosis. Maybe it's because they're not having as many periods. It's difficult to know. But obviously there are people with both. But they don't seem to be linked.
So we've got loads of time. We've got teas and coffees out there. I'm really pleased Jan did mention that it's okay to eat carbohydrates because it's Danish pastries as well. Appropriately for Robert. I'm going to finish with one last question. Well, it's not a question anyway. If I had a magic wand, and I'm thinking to direct this to everyone, but I'm going to direct it to Cassia first of all. If I had a magic wand I could wave, in terms of research, because I think we've heard enough tonight to know that we need more research. We need to do better. What is it that's missing? What needs to come? What we fix the problem? What do we need for research? Do we need more ideas? What is it?
I think we've got ideas, we need money. That's my magic wand.
More money, but we've also heard from Colin that it's difficult because the pharmaceutical industry are perhaps not involved. Colin, what would you do? One thing that we can make. What do you need?
I think that we need a UK-wide research network that is funded to work with women and answer the questions that we don't know about. And I think that because we can't do it by ourselves, I think we need to club together. And I think that if you would say to me, well, I want a virtual research network for the whole of the UK where we're working together to answer the questions of polycystic ovary syndrome. I think from a clinical perspective that would be right, and I think that Cassia, from a scientific perspective, would be generating some ideas, but I think we need to be testing these ideas, and I don't think we are just now.
John, same question to you.
First of all, I want to say I totally agree with Cassia and Colin with their points. That's definitely needed. I think as a charity's standpoint, I think terminology, I think education around the condition needs to be better. Because when you are diagnosing and the terminology that you're using, that's the most important part of that female's life, because she's just been given a condition and she's got no idea. So I think in terms of diagnosis and terminology needs to be accurate for all.
Money, cooperation, education. Thank you.
A big greedy one.
One last thing first. It's really important with events such as this that we actually evaluate whether or not it's worthwhile. So this magical title should take you to a very, very short questionnaire. I mean, super short. And if you could fill that in, then your feedback actually is really important because it lets us know what was good, what wasn't good, what we should do in the future. And it also keeps my funders of this event happy as well. So it's really important to me because otherwise I'll have to do. I want to say a massive, massive thank you before we go for coffee. And please do go and speak to our panel over coffee. Please do. I want to say a massive thanks to Edinburgh Napier University's Public Engagement Fund for supporting us this evening. I want to say a massive thanks to my glamorous assistant at the microphone, Professor Peter Barlow, who is the director of the Research Centre at the Centre for Biomedicine and Global Health here at Napier, who facilitated this event tonight. I want to say a huge thank you to the panel because The other one's true, isn't it? But as a big thank you to yourselves for coming along, because what's the point? So thank you very much, and please, let's have coffee for each pastries.